Good afternoon. Male 21 closed injury, mid-substance tender Achilles rupture, and I opened it, and when I opened it, I found the complete tear, which I debrided, and open repair was done, which was a successful repair. And he went on to do fine, and it was like a great end result. So I thought, yes, the open tear repair mid-substance works well. Then this was a compound injury where a 10 years old state level badminton champion had a monkey bite while playing, and then this was a compound segmental tear of tender Achilles, which I repaired with an open tear repair, and she did fantastically well. She went back to play badminton and she was doing well. So I said, oh, I am an open tear repair boy. But then it was this case where I openly repaired tender Achilles, and then there was infection. I had to go in twice, and it was ultimately that I had to resort to flexor hallucis longus transfer and a big plastic surgical reconstruction. So like WIROC theme, I thought that it's a time to adopt and evolve. So before answering this question, how do I treat mid-substance Achilles tear in young active patient? If we go back to literature, traditional open crack or sutures, though, was very good, but this series said that the 20% wound complication, and a recent series said that up to 34% complications are noticed in this open repair. So if not surgery, then what? Hajo Thurman et al. Came with this, where they said that you could treat mid-substance Achilles tear conservatively if the ends meet by 20 degree of plantar flexion in ultrasonography or MRI. You can give a functional brace and can mobilize them, and they can go back to routine spots by the end of 1 year. And the complication rate was very less, 2 to 3% and 2% of re-rupture rate. So this was an eye-opener, and then the debate started whether to operate or not to operate tender Achilles. The literature before 2010 was quite dubious. It was either supporting both, right? So this study said surgery has low re-rupture rate. This study said though surgery has low re-rupture rate, there are high complications in form of wound issues. This prospective randomized study concluded that surgery is better, but non-operating is also acceptable. And these three studies say that there are high re-rupture rate when you treat conservatively. But it was the literature after 2010 which was specific, where they compare operative versus non-operative modalities. And they said that there is no difference whether you operate or you conserve. This study said that yes, there are no difference between you operate and conserve, but when you operate, there is increased plantar flexion strength. This largest study onto non-operative functional management of Achilles rupture said that re-rupture rate was less than 2.8%. Meta-analysis also said that. They said that higher complications with regards to surgery. There was no difference in surgery versus conservative treatment in this study, but they said you must consider non-operative treatment if your center has a good functional rehab protocol. What is the literature saying today? Today, overall, the complication rates are same. Overall success rates are same whether you operate or you don't operate. But the plantar flexion strength at 1 and 2 years is higher when you operate these cases. That is the today's tune. What about MIS? MIS was also going on well. These debates were going on. And MIS, one study said that the strength of percutaneous repair is little poor than the open repair. And there were a lot of complications in form of sural nerve injury. But it was in 2006 when this study where a Achillon device was used was a like kind of a outbreaking kind of a study where MIS came up in a big way. And then all these studies, they said that there is a good strength when you do MIS or you do open repair, and the complication rates are less. So a lot of MIS devices and techniques came in. This was a gift box technique which was described with a good 87% success rate. And Hans Zwiep et al., they developed an instrument which is named as Dresden, and through this instrument, two suture in proximal and two suture in distal stump of the ruptured tendon is taken, they also showed good results. This study, they developed a ring forceps with a curve, and they found 2 sutures in proximal and distal tendon gave good result. As Aquilon device obviously is a good device with a good success rate. Arthrex came up with this device, PARS, which is a costlier device. It allows 2 locking sutures, and sutures in multiple planes are being taken, and the studies showed that PARS device has worked very well, and it is giving 10 times stronger tendon strength vis-a-vis Aquilon. And this is the latest one, where a percutaneous knotless technique with a knotless suture anchor, where you do the sutures through the PARS and the sutures into the tendon Achilles insertion. So the question is, what I do to answer this question today? My management goals are a healed but not elongated tendon is what I want. I want minimum risk of re-rupture. I want to maintain the strength and function of tendon Achilles with minimum immobilization so that I don't get muscle atrophy, and I want to avoid complications like wound breakdown and infection. So it is the minimally invasive repair which has best of the both worlds. So I do minimally invasive repair in an adult patient who comes with a mid-substance tendon Achilles tear with me. So for every adult, what I do, I mark out the ruptured ends of the tendon and I mark out my vertical incision. I put in a vertical incision, I go into the paratenon, and with the Ellis forceps I pull out the tendon, and I pass 3 locking sutures like one which you get through the PARS assembly. And with that I also pass 3 locking suture into the distal end of the tendon, and then I tie it at the junction. And this has worked well for every adult whom I have treated, and this is how the diagrammatic representation of this repair seems. For a sports population, I am passing sutures into the proximal segment of ruptured tendon Achilles either with a percutaneous technique or with the Aquilon device, which is readily available and cheap to us, and these sutures are then passed through the tendon Achilles insertion with a curved lasso needle, and then it is fixed to the calcaneus using 2 4.75 knotless suture anchors, and this also works very well. Yes, there are patients who refuse surgery. Mid-substance tendon Achilles tear in an adult patient refusing surgery. Like this case, a female of 32, 90 kg had a TA tear. She refused surgery. I did the ultrasound. The ends were matching at 20-degree plantar flexion, and I treated her conservatively with the brace, and she did. Oh, this video is not running. And she did. Sorry, this video is not running. She did fantastically well. Next slide. It is stuck. Yeah. Next slide. So you're going to ask me, show me the evidence whether MIS works as good as open. Yes, there are so many studies. In this study, 3 times greater patient satisfaction vis-a-vis open was gained. In this study, MIS gave more neurological complications, but it was comparable to the open surgery. And this is the latest one, which says that minimally invasive surgery was significantly favored over open repair for complications. And I go in for aggressive post-op rehab in form of anterior POP slab in neutral position for 3 weeks, followed by mobilization at 3 weeks, followed by weight bearing at 6 weeks, and activities of daily living by 12 weeks. That's all. Thank you very much. Thank you, Bombay Orthopaedic Society.